The following program was produced by an independent community producer. The opinions expressed do not necessarily reflect those of the ECAT staff or board of directors.
Welcome to Well Informed. Well Informed is an affiliate of the Retirement Education Resource Center of North America. The Retirement Education Resource Center of North America is intended to be an educational awareness organization. We do not advise, market, or refer services. The content and discussions presented in this program are for broad informational purposes only and are not to be replaced, used, or misconstrued as professional advice. Please consult your advisor for information pertaining to your personal individual situation. My name is Marques Cardoza. I'm your host. My guests are Teresa Dolloff from Stoughton V&A, Michael Cruza from Old Colony Hospice and Palliative Care, Rebecca Garabedian from Unique Home Care Services, and Diana Rodrigues from OCES, formerly known as Old Colony Elder Services. Today's episode is one of a series of long-term care planning. Today's topic is home health care services. Welcome, everybody, and thank you for being here.
Thank you
Thanks.
for having us.
Thank you.
My pleasure. Teresa, let's start with you.
Okay.
So first, I'm going to refer to my notes. First, tell us what goes on before a person begins VNA services, and describe when a person starts and ends VNA services.
Okay, first of all, my name is Teresa Dolloff. I'm from the Stoughton Public Health Association and visiting nurses. I'm a community liaison and quality improvement nurse there. What goes into, how does a patient get referred? What happens first? So typically we get our referrals from either a hospital or a rehab facility, and in many situations those patients have had an acute hospital stay, a new illness, or perhaps they've had surgery. Perhaps they've gone to their physician and they have a new diagnosis, or they're on a new medication, and the physician or the discharging agency feels as if they need some additional skilled support when they're in the home. And the reason why I say skilled is we're a skilled nursing agency. That means the care that we provide is provided by skilled clinicians, registered nurses, physical therapists, occupational therapists, medical social workers, and we also provide the home health aides as well.
Nice.
Mm-hmm. What was the second part of your question?
Tell us how the options a person has when a doctor prescribes VNA services. Do they have an option of, does the doctor tell them where to go, or do they have?
Well, we have what we call patient choice, and patient choice means that when you're leaving a hospital or a rehab, or when the physician refers you, that physician or discharge agency, either the case manager or the social worker, should provide you with a list of skilled agencies within your geographic area that can provide the care that's required. From that list, the patient is supposed to have an opportunity to review them and then select their own home care agency. Many times, what we find is that the discharging agency will pick a home care that they're either familiar with, and patients often say they don't get a list, or perhaps they wanted us and they were referred somewhere else, and they call and they say, I don't know why I didn't get you. We're supposed to have you.
Right.
Many times when I speak to discharge planners about this, what they say is, well, they've used a particular home care in the past. And my response to that is always, patients are healthcare consumers, just like we're consumers. So if you're a one-time Walmart shopper, it doesn't mean that you're not going to go to Target another time. The patient should really have their choice every single time that they're going to utilize a service. And that's what we promote a lot.
Right. So if a person goes to the doctor and the doctor says, I want you to, this happened to me recently with my mother. The doctor wanted to have PT, and the doctor gave us a place to go with PT. It was in Westwood. I said, well, why would we go all the way to Westwood when we have two of them here right in Easton? And they said, okay, yes, we'll send you the Easton one. But we had to ask for that. So what you're telling me is they should have presented me with a list of places we could have gone. Like when you get in a car accident, they give you a list of places where you get your dent fixed.
Right. Right, exactly that. They should be provided with a list so that they can choose. They can make their own informed decisions.
Would you say VNA is an extension of the doctor's services after the hospital? It's sort of a thought because they report right to the doctor, right?
In order to receive home care services, a few things need to happen. It has to be ordered by a physician. It needs to be reasonable and medically necessary. The patient needs to be homebound, which means that it would take a great effort in order for them to leave the home. They can leave the home for maybe a religious service, but you can't be receiving home care services and heading down to Dunkin' Donuts every day and hanging out with your friends. And,
Too bad.
Right, I know.
Will you bring the Dunkin' Donuts?
What's that?
Will you bring the coffee?
To the patients?
Yeah?
Probably not. Probably not.
But that's a good point. It's a good point that what you've made.
Right.
It's important for them to have their choice.
Absolutely. We choose our primary care physicians based upon what's in our payer network, and
patient choice.
It should be that way. It's actually a law. Mm-hmm.
Oh, okay.
Mm-hmm. Yeah, but it's funny when you go places and you speak to these discharge planners. They're like, "Oh, a list?" I said, "Yes, a list. Can I see your list? Can we make sure you're on your list?" So, but for the most part, with our patients, we're a very small VNA, and they really, really like us. So they tend to be our biggest advocates.
Well, one of the things you mentioned to me before, Stoughton VNA is one of the only 2 VNAs in the state.
Correct. So in the state of Massachusetts, there's 351 cities and towns, and Stoughton is one of 2 that's owned and operated by the municipality itself. So Stoughton Public Health and Visiting Nurses is owned by the town of Stoughton. And there's also one in Acton, but we're the only 2.
So you're sitting in Easton today.
I am.
But you're from Stoughton.
Exactly. We just do not service Stoughton, which makes our name deceiving, right?
Right.
But we service Stoughton, Easton, Canton, Sharon, Avon, Randolph, Brockton. So we service any community that's touching the town of Stoughton.
Awesome. So Easton touches Stoughton.
Easton does. We have several patients in Easton.
So how do they get in touch with Stoughton VNA?
Typically, because the service is ordered by a physician or a discharging agency, they will speak to the discharge planner or the physician and say, well, I want my referral to go to Stoughton Visiting Nurses. Sometimes we have patients call us and say, well, I'm going in for a knee replacement. I want to make sure that I have you folks, and we instruct them to do so. And we'll contact the physician's office and say, you know, Mary Jones is going in for a knee replacement next week. She's requested us for services. Could you please forward the referral at the appropriate time? And
awesome.
Yeah.
Thank you.
You're
Anything
welcome.
else you'd like to say?
I don't think so. If it comes up, I'll let you know.
Okay. Michael.
Yes.
Old Colony Hospice Palliative Care.
Mm-hmm.
The biggest confusion in my world is what's the difference between hospice and palliative care?
Mm-hmm.
Go for it.
Yeah, it's the biggest misconception / confusion, and it really does stump a lot of people. Even we've had nurses who've come to work for Old Colony Hospice with no experience about what a palliative care consultation is, and we have to let them know, and they've already been seasoned hospice nurses. So it's tough. So in order to understand really what palliative care is, we should really talk about hospice care. And when anyone talks about hospice care, what's the first thing that everyone thinks about?
Death.
Death, yes. So it's death and dying. But it's really not. It's really about life and living the best you possibly can for as long as you have. In fact, in the recent maybe decade, there's been a handful of studies where they've taken patients with the same diagnosis and prognosis, and they've looked at half of that group had hospice and the other half didn't. And the group that actually had hospice care lived on average 29 days longer. So the old idea of I'm not ready for mom or dad or my loved one to get hospice care because I'm not ready for them to leave me, it's actually the opposite. If we want to keep our loved ones around a little bit longer, the idea is to actually initiate hospice.
Now, I've had people in hospice, and I've had one woman in there for over 1.5 years, almost 2 years.
Yeah.
And they call it the extended care.
Yeah, well, what happens is we get patients sometimes and we start to really dig into what their symptom management concerns are, their pain management concerns are, and they start to do better. We also are able to keep them out of the hospital. And when you do those things, people's immune systems start to get a little bit better. They start to become a little bit stronger. They get actually more rest at home when they're not in the hospital. And people can actually do a little bit better and stick around a little bit longer.
So that's where I'm confused. I had this person in there for over a year and a half, but yet it was hospice. So where does palliative care fit in?
Right. So where hospice is more it has to be really in the last 6 months of life, or if the disease continues to go protracted and continues on, you can still stay on hospice care. But you really have to meet those guidelines as you move forward. With palliative care, you don't have to be towards the end of life. You can actually have VNA services. So at times we have people who are on with VNA, but we also provide palliative care services because it's billed through a different part of Medicare.
Oh.
So we're able to go in with the VNA and actually provide the same philosophy as hospice care. So with palliative care consults, we are focused on pain and symptom management. We're looking at advanced directives and what might happen next, so we can prepare people so they stay out of the hospital. But the bad news with palliative care is that it's only intermittent. So we're hospice care. You really have access to the hospice team 24 hours a day, 7 days a week. So if something goes sideways and it's 2 a.m. on Thanksgiving, we're there. You call us and we can actually come out to the house and treat your symptoms, find out what's going on and really make sure that you're comfortable. Palliative care, on the other hand, is really a consultation service in that it's Monday through Friday, 9 to 5. A nurse practitioner who's an expert in palliative care would come out to wherever you are. So both palliative care and hospice care occur wherever somebody is.
How do I know which one I need?
That's a good question, because some people do qualify for both or neither. So palliative care, because palliative care we have more of a pool of eligibility because you can get it at any point of the disease process. There's a lot more people who can benefit from it. So anybody who has a progressive, chronic, advancing illness, right? So any of like COPD, CHF, renal disease, liver disease, even some of the progressive neurological diseases like Huntington's and Parkinson's. If they've got a progressive disease that starts to have symptoms that are not well controlled or cause people to go to the hospital, that's when you really want to have a palliative care consult to find out what other interventions could we put in place to keep someone at home or be prepared for what might happen next.
Can I just call you to get a consult, or do I have to go to my doctor?
Actually, anyone can initiate the conversation and start the referral process. With palliative care and hospice care, we get calls all the time from family members, and they will give us their PCP or their specialist's phone number, and we'll reach out to them and say, hey, listen, we got a call from Mrs. Smith. She's your patient. They're looking to really look into some symptom management with this disease process, and ask them if they would be okay with writing the order.
You know what's interesting? When I first started shopping for this person needed hospice, she was in a nursing home. So what was interesting is I realized that Old Colony is a nonprofit, whereas others aren't.
Right.
And I was surprised because I thought all hospices were nonprofit.
I think that they should be. It's kind of hard to imagine, making profits off of somebody's end-of-life experience. Old Colony Hospice and palliative care is one of, in the same way you've got a kind of a small group of people who are exactly like you. Old Colony Hospice is only one of, I think, 3 remaining independent freestanding nonprofit hospices left in the Commonwealth. And there's 110 hospices in all of Massachusetts. So you'd think it'd be a lot less.
Yeah.
But the vast majority of those hospice licenses are for-profits. At some point around the year 2000, hedge funds and other corporations found out there was profit to be made in providing end-of-life care, and the licenses just started being produced.
Yeah, we want to be totally transparent here,
Sure.
because this is an unbiased platform.
Yep.
I think Old Colony Hospice has done a wonderful job. My father, you had my father, he passed
awesome.
away. But also I've had great experiences with profit too, for-profit hospices. So I think as the viewers should think about is to know that there are choices. Same thing as VNA. There are choices. And if they're presented, if they're in a nursing home and they're presented with a hospice, a lot of times nursing homes have their own hospice,
Sure.
which can be good and bad.
Mhm.
So it's the choice of the families not to just take the hospice that is being recommended.
Right.
Ask for a choice of hospices.
Right.
Because some hospices fit differently than other hospices,
And
which is a good thing.
And there's actually, in the last couple of years, any consumer can go online now and really look at the quality surveys of a nursing home, a VNA, and even hospices now.
Yeah.
So anybody who even sees the list that the nursing home or the discharge planners at the hospitals have, they can actually go right online on a smartphone and just really look up the quality scores and choose the one that they feel is the best one that fits their needs.
Right. I noticed some of them are more geared to religion, some of them more geared towards music, some of them, they have different expertises, which is good to know.
Yeah. Oh yeah, that's excellent.
But you guys have done a great job. I mean,
well,
we're
thank
always
you.
happy. And that's what made me surprised to think that they're for-profit hospices. But I guess everything gets commercialized
Yep.
one way or the other. Is there
Sure.
anything else you want to tell us? How do we get in touch with you?
Like I said, anyone can give us a call. We're right over in West Bridgewater. We cover all the way up to Dorchester, down to Plymouth, and then all the way across to Attleboro and up to Dedham, Westwood, Norwood, the woods and the hams,
Nice.
and everywhere in between. So if anyone
Awesome.
needs us, they can call us or find us online. The phone number is 781-341-4145.
Awesome. Thank you.
Thanks.
Thanks for joining us today.
My pleasure.
We'll have questions in a few minutes.
Yeah, I know.
Diana.
Yes.
We're on. So, OCES.
Yes,
My mother, she loves you, by the way. She says hi. Hello.
she is wonderful.
So tell us about your services. When does somebody implement your services? How do you get involved in a person's life?
Okay, so OCES stands for Old Colony Elder Services, not to be confused with Old Colony Hospice, which is entirely different.
Yeah, you're two different affiliates.
Yes,
I
but with
learned
the
that
same
today.
name, that gets a
Yeah.
little confusing sometimes. But so Old Colony is one of the aging service access points. There's 23 in the state of Massachusetts. So we cover all of Plymouth County and also Easton, which is Bristol County, Stoughton, and Avon. So all of Plymouth County, which is from Rockland to Plymouth, basically, or Marshfield to like Stoughton, Easton, Stoughton, and Avon. So we help really anyone that needs help, and I think that's why we have veered away from going by elder services, because it doesn't only service elders. And I think that sometimes there is a common misconception with elders. If you have elder in the name, people might think, oh, I'm not old enough to receive services, or so I think we were just trying to be a little more progressive, and to go by the OCES makes things a little more fluid.
Well, I think it's also because, as we discussed, you're not just for elder services. There are a bunch of other
right.
services that fall under that umbrella.
Mm-hmm. So we offer a multitude of services, but what I'm an expert in and what I'm here to talk about primarily is the home care department. So that is geared towards anyone over the age of 60. You would be eligible for services if you had a dementia diagnosis under the age of 60. But typically it's anyone living in those towns over the age of 60 and who needs help in certain areas, certain activities of daily living.
So I qualify as far as age is concerned.
Perhaps, but maybe not in some other areas.
That's right, just age. Go for it.
But we certainly wouldn't turn anyone away. So if there's anyone who's in need of services, I encourage them to call. Because if it's a service that we can offer, we certainly will. And if not, we can provide other referrals and information as well. But for home care services, so if you're watching in the Easton area, you may have seen me in your home before. I've been a case manager for nearly a decade, and now I am the new home care intake supervisor. So any new referrals that are coming in will be coming to me and my team, and they are the ones who are going out to see people for initial referrals to evaluate them for services. And some of the different services we offer are home delivered meals, Meals on Wheels, homemaking service, which is light housework, help with preparing meals, shopping, laundry. We also have home health aides who can help with bathing or dressing. Basically what we do is we contract with other provider agencies that provide the care. So we at Old Colony, we're not going out and providing this care. We're doing the evaluation, and then we're linking you with the agencies that can provide that care.
I think I don't mean to cut you short, but I think one of the biggest things that you have is that button or the watch.
Yes, the Lifeline Button.
Yes. Yes.
And there's a few different options too, depending on people's needs and depending on if they have a landline or not. But yes, the Lifeline,
That's huge.
the old I've fallen and I can't get up button, which is how people
yeah.
remember from the commercial back in the day. But that is huge because sometimes people are afraid to go in the shower,
Right.
or afraid to leave their homes, or afraid to do different things because of the fear of falling.
Yeah.
So having that button is that extra assurance that help is just a fingertip away, basically.
Now, you with your services, you qualify medically and financially.
So it's based on age, need, and income.
Okay. So how many hours a day? What's your maximum number of hours a week?
It really depends. It depends on which program that people fall into. Mass health is certainly something that opens up a lot of doors. So if someone was on mass health, they could get many hours of services. Without mass health, we are limited because we do have to go by state and federal guidelines and budgets. So it depends. It could be if someone just needs help with some grocery shopping and laundry, maybe that's 3 hours a week. If someone also needs help with bathing and dressing, then maybe that's a few more hours.
So subjective.
It is, and it's hard because we like things to be black and white, but nothing is black and white. It really depends on people's needs, and we try to find a creative way to meet those needs, even if that's past what we may normally authorize. Or we could potentially work with other agencies to provide them round-the-clock care between our services and
So
others.
does VNA get involved?
Yep. Yep, absolutely.
Michael?
And home care, VNA, hospice, all of these can work.
So you guys all overlap.
We
So
can,
like-
yep. It does require us to communicate with one another and ensure that we're not providing the same care at the same time. We don't want to duplicate the services. But if VNA has home health aide going in on Tuesday and Thursday, we could have one of our agencies go in on Monday, Wednesday, Friday.
Oh, that's great.
Folks a lot.
Mm-hmm.
Yeah.
How long do your services usually last in a home?
It's short term and intermittent, but it really depends on the patient's picture. It's something like a knee or a hip that might be like 6 weeks, 4 weeks.
So it's acute.
It's meant to be temporary. It's a temporary intermittent care.
Okay.
Yes. Yep.
And yours is chronic.
Yep, ours is at any
For
at
long.
any point that they need it and at any point that they want to stop,
Nice.
if at all.
So how does a person get in hold of you?
So the first start would either be checking out our website, which you could put on the bottom
Sure.
of the screen. I can provide to you later.
No, tell us right now.
www.ocesma.org.
OCES.ma.org.
Nope, not that
Okay.
dot.
OCES.
ocesma.org.
Okay.
And then also you could call us at 508-584-1561. And then you would want to speak to someone in our information and referral department, and from there they can link you with either home care or another department that might be
Do I
right
need
for
a
you.
doctor's referral?
You do not. Anyone can make a referral. You can make one for yourself. You can make one for your mother, your son, your neighbor, anyone that you think might be in need. You can make a referral. They do have to be willing to accept services. So you might think that your neighbor Mary needs services, but if Mary doesn't want it, we certainly can't force her.
Teresa and I are familiar with that, right?
Yes.
Yes, for sure.
Anything else you want to tell us?
No, just that I think Old Colony is a great resource in the community, and we offer so many different programs that anything could help pretty much anyone. We have family caregiver support programs. We have an adult family care program, which is a mass health program where people can be a paid caregiver. If you're living with a loved one, you could be a paid caregiver. We offer money management programs if someone's having trouble paying bills. We also have a new community transitions liaison program, which is people transitioning home from rehabs and nursing facilities. So that's another kind of new revamped program that we're working on. So really, I mean, if you know of anyone who needs any help at any stage, give us a call and we'll be able to help.
Nice, thanks.
Yeah.
So Rebecca has unique home care service. You're a private organization
Yes.
and you own it.
Yes.
Great. The reason why I asked you to come today was a couple of reasons. I've known you for a number of years and you do a great job. But you're not a part of the PACE program, but you service a lot of the PACE participants
Right.
indirectly from PACE. Is that correct?
Right.
Great. Wonderful. Because I want to point that out because we've done a 1-hour documentary on the PACE program that will be aired in these series. So it's a great thing to know. So tell us about your services and tell us how you fit in to everything here.
I mean, Teresa and Michael and
Diana.
They all mentioned home care services, and we almost do the same thing.
Mhm.
I can say we can continue their services for as long as the client needs. If the client has like chronic illness and needs continuation of services until they become hospice, let's say, or until they become better, then we are there. We are there to help with any kind of situations that the client has or the patient has.
So you cook for them?
So we prep meals. We remind them of their medication, personal care, if they need shower, bathing, dressing. If they need any, like if they have a surgery and they need to follow some physical therapy exercises, that the physical therapist give them, a paper with all these exercises. The aide will help with these exercises at home, in addition to the physical therapy visits.
Mhm.
So anything that needs a person at home for the well-being of that person after a surgery or injury or illness or discharge from a hospital or rehab, we are there to help.
We see a lot of your services popping up, and I know you've been pretty heavy in the area. And I think as people get older, services become more necessary.
Right.
We have a person that's in hospice, just died last week,
Right.
and he was in hospice, and you had respite care at their home, which worked out really nicely.
Right.
So you work in conjunction with VNA?
With VNA, with hospice.
And with other services
Right.
and you work in conjunction with OCES and Hospice Care. Right. So question, how do you all get paid? Who pays you?
Insurances. So
Insurance.
most facilities have a list of
Health
payers.
insurance?
Health insurance.
Okay.
So we take Medicare, we take several Medicare Advantage programs like Tufts, Aetna, We take all Harvard Pilgrim products, HPI, Workman's Comp. That's how we're paid.
Workman's comp.
Mhm.
How about you guys?
Hospice is, because the vast majority of our patients are older, right? About 95% is Medicare and or Medicaid. And it should also just be noted that hospice care is covered at 100%. So even if you have Medicare only, which is traditionally an 80% coverage, 20% copay on a lot of things, that's not the case when someone's on hospice. It's 100% covered. That includes all of the visits we provide from all the disciplines. It also includes 100% coverage on the equipment and the medications that are needed to keep people pain-free and symptom-free.
One thing we haven't touched upon is long-term care insurance.
Mm.
And I know long-term care insurance pays for your services.
Well, long-term care insurance doesn't pay for hospice.
Okay.
Sometimes it'll help to pay for if somebody's in a facility per se, if they have some extra insurance. But hospice is strictly paid for just by the insurance. And because we're a not-for-profit, if someone just happens to not have insurance, we actually provide free care. So that's part of the gig with being a not-for-profit is required to do some free care if it's needed.
Diana, can a person use your services as well as the services paid for by a long-term care insurance policy?
I believe so. I think that's pretty rare. But I have had a few cases where the long-term care insurance helped pay for their services through us.
Okay. And Rebecca?
Long-term care, yes.
So there's a good way of paying for it. So there's several options for paying for services. It's just a matter of, so I know when a person is ill and the family is tied up in the whole thing, it's hard to sort it all out and decipher.
Mm-hmm.
So what do you recommend they do? You run into it all the time when you're visiting nurses, families that are just engulfed in the problem. And I'm sure, probably before you even get there, because you're usually the solution to the problem, and you guys must run into it a lot. What do we do?
Provide support.
A lot of teaching. It's overwhelming for someone to come home
Absolutely.
and all of a sudden that 24/7 care is gone. They're overwhelmed by a diagnosis. They're overwhelmed by not feeling well. You have family members who are anxious because I'm not a clinician. How do I take care of them? So we provide the orders as the physician has ordered them for a particular patient, but we do a lot of teaching, a lot of support. We're available by phone 24 hours. We go out to patients in the middle of the night or on weekends if need be.
So they're not alone.
No.
No, they just have to know where to reach out.
And we
Awesome.
make that really clear.
Yeah.
We
So-
don't want them to ever feel like they're
Michael-
stuck.
Michael, we know when your services end,
Right.
unfortunately.
Yeah.
But Teresa, when do your services end with a person?
Typically, our services end when they reach their goals, or when one of those qualifiers is no longer met. For instance, it's no longer medically necessary for them to receive home care services, or perhaps they're not homebound anymore. Many times we'll discharge patients who are receiving, like for instance, we have a couple patients right now who are going to be getting discharged to outpatient services for their physical therapy because they're no longer homebound. So
Nice. They've graduated.
they've graduated.
Yeah. Diana, when does a person leave your services?
Really, services are ongoing for
right.
however long they need it. So until they tell us they don't want it anymore, they can continue to receive it.
And Rebecca, you're the same.
Same,
Yeah.
as long as they need it.
That's great. So, oh God, let's go down these questions. When does a person first receive services? We know when they're discharged. The doctor tells us. We've discussed that when.
Yeah, for palliative, it's really at any point of a disease process, or even when they're having symptoms from their treatments. And then hospice, obviously, it's when somebody's really, needs that extra care towards the end of life.
Yeah, and you guys all interact with each other, and you can combine services.
We often receive referrals from hospice and VNA for ongoing services.
So you guys all know each other.
More or less.
Not personally, but I refer to both
Our
of
agencies
them.
yes, know each other very
Now we
well.
do.
You don't
Right,
know each other,
exactly.
but you've referred to each other. That's great. And I think we've answered all the questions. Is there anything else you guys want to tell us? Let's start, Teresa. What else do you want to tell the
About
viewers?
the VNA. We're a small VNA. We're a very small agency, and we really look at that as a positive because we're so small, we can get our clinicians out very quickly, so patients access that care very, very quickly into being discharged home. Sometimes we get out the same day because that is when the patient and the family is so anxious. The other thing that's really good about us being small is patients are seeing the same clinicians pretty much. So they build a relationship with their clinicians, and because of that relationship, we think that they're more comfortable communicating symptoms that they maybe wouldn't if they weren't familiar with somebody. So that allows us to treat them better. People sometimes think, oh, you're very small, but our patients love us because we're small, because they see they have continuity of care, and that's important. We pick up on things faster than somebody who's only sees a patient once. So,
Great. Michael.
I think just a couple, what we really didn't dive into is just who's on that hospice team, right?
Okay.
And we acknowledge that the nurse is really responsible for coming out, and they can help in the middle of the night. But there's also a social worker that can help out with any type of planning, but also family dynamics. And they're really instrumental in guiding families along this last part of someone's journey. And then we also have chaplains on staff. So if anyone has spiritual questions that do come up towards the end of life, they've got somebody at the ready that can come to their home or wherever they are and really answer those questions. As well as we have home health aides that can come out for personal care. We have volunteers that do anything from pet therapy through Reiki, or even just sitting at the bedside so family members can take a break. So there's a lot more to the hospice team than I think the word hospice and all its other baggage would let on. So I always like to make sure that everyone knows it's not just about the pain and the symptoms. It's about the patient, what's happening, but also the family and how that works together.
Yeah, and I think people shouldn't be afraid of hospice.
Right. More or less, when no one's ever said, I wish I had known later.
Right.
They always say, oh, I wish I had known sooner.
one thing that I was surprised about when I had utilized hospice for a family member was the availability after.
Oh, sure, yeah.
And all the support after. And,
Yeah.
when you're processing it, you have these resources available to you that are
Right.
helpful.
Yeah, so essentially, if someone's been on hospice for 3 hours, 3 months, or even a year, right? And then after they do pass, we proactively contact through bereavement services.
Nice.
So we reach out to the family for 13 months after someone's passing. And that's so we cover all of those anniversaries that have a glaring omission now, plus a month after the death. So
Nice.
Yeah.
Awesome. Diana, anything else you'd like to tell us?
No, I think just if anyone is in need in the community, don't hesitate to reach out and see what might be available to you. I think a lot of times people come to us when they're most vulnerable and when they don't really know where to turn and they're overwhelmed. And you actually could come to us sooner than that. You could come to us when you're not quite sure what next steps you might take, and we might be able to advise you on those. But if you do come to us when you're in need, we'll certainly work with you to try to get you all the services that you need.
Right. I think it's important that they reach out.
Absolutely.
I don't want to coin the phrase reach out and touch someone.
It's true, but you don't know until you know.
Right.
Right.
Rebecca?
Unique Home Care is a small business.
Yeah.
And our motto is to provide quality care. So we have our aides are all trained and background checked. We provide them with insurances, workers' comp, training, supervision. And as Teresa said, because we are small, anytime a client calls or an aide calls, we are there.
Yeah. Training's huge.
Yes, and then the client always calls and hears the same voice, which is my voice, of course. But,
Yeah.
it's not like the client is transferred from one department to another, and then each person gives a different scenario to the client. So
Nice.
this is
Yeah, it's hard to get our labor force up to date.
Right.
in that area. I know you guys have a lot of training as well.
Yeah, so we contract with all of our provider agencies like yours, and they're vetted through our contracts department. So a lot of the same. They're all provided similar training, and quality is certainly important. And we do quality checks intermittently as well.
Important.
Right.
Mhm.
The same with your Michael, your training.
Oh yeah, I mean it's
Intense
extensive. The vast majority of our employees are all certified in hospice and palliative care.
Yeah.
So some, when they come on, and then we actually help them to go through that training to really be the frontline pain and symptom management team, to really know the stuff and make sure we keep people pain-free, we keep them symptoms managed, and again, keep them out of the hospital. We tell people all the time that the hospital is no place for sick people.
No,
And if you think about it, if you're towards your end of life and you've got this chronic disease, staying out of the hospital is probably one of the better things that you can do.
Teresa, do you do a lot of training as an RN? Do you do a lot of training to your staff? And do you have a training crew?
Well, we're all licensed clinicians, and we all have to maintain our CEUs for licensure and whatnot. But we're all forever having webinars and
Right.
whatnot to keep
Yeah.
current with
Yep.
with the industry and whatnot. But
That's
I think the goal probably for all of us is to just keep patients home and healthy, meeting their goals so that they can stay home. You're right. The hospital is no place for sick
Yeah.
people.
No.
It seems counterintuitive, but I mean,
It really does.
hospitals are great. If you need a surgery, if you get a procedure, if you're otherwise doing well and you need those things. But if you've got a advancing chronic progressive disease that can be managed at home, it's better for everyone. Patients, families, even the Medicare system, because it's less expensive to keep people at home.
I think we've answered a lot of the questions that the viewers might ask.
Sure.
I want to know. I know you've clarified a lot for me on what's going on. So I'd like to thank and extend my gratitude to ECAT for allowing us to share this content with their viewers. We hope you found the episode helpful, and please look forward to other topics that we have. We have them on PACE, assisted living, tax planning for retirement, and also estate planning, which all coordinate into some of these topics. This one here is obviously on one topic on long-term care planning. ECAT thrives on sponsorships and one-time or monthly donations. Please donate to ECAT. The Retirement Education Center of North America is offering a copy of Positioning for Retirement for a $20 donation to ECAT, and a digital copy sent to your email address for $10. You can also find this document on the local author's shelf at the Ames Free Library. Okay, so thank you for joining us today, and please stay safe and well informed. We're different. Our focus is on estate and elder insurance planning. Our mission is to protect your estate from being spent down for long-term care. You may never need care, but it's good to be prepared. Know your options and create a plan. We work hard to protect what you worked hard to build.